Hello everyone. Today I'm going to present to you about hepatorenal syndrome. We're going to help differentiate hepatorenal syndrome from other causes of acute kidney injury and decompensated liver disease, discuss the pathophysiology with emphasis on compromised renal hemodynamics, discuss the current definitions with hepatorenal syndrome and some problematic aspects of the definitions, and also discuss some principles of treatment of hepatorenal syndrome with emphasis on improved volume assessment and management. There are many potential mechanisms of acute kidney injury in patients who have decompensated liver disease. And this slide is to show you that there is a differential diagnosis of acute kidney injury and hepatorenal disease, even though clinicians are very quick to write hepatorenal syndrome on the patient's charts. The principles of supportive care for treatment of acute kidney injury and decompensated liver disease have not changed for many years. If a patient is hypovolemic, treat the hypovolemia. If they're hypervolemic, treat the hypervolemia. You treat all infections, bleeding. You treat encephalopathy. You evaluate the patient for liver transplant. You try not to insult the kidneys. And if the patient needs it, you might consider dialysis. There are some aspects of hepatorenal physiology that are very complex, but these are some very basic things that we know about it. When people have kidney failure in decompensated liver disease, it is often reversible, the kidney failure, after the patient gets a liver transplant. If such a patient dies before they get a liver transplant and their kidneys are harvested and transplanted into a patient with a healthy liver, those kidneys will often work. The only known treatment for hepatorenal syndrome is to improve the kidney perfusion. The kidney function might be able to be replaced by hemodialysis. And the liver treatment and prognosis depends on the underlying disease, but there is no machine to replace the liver function well. This is one of the best slides from an academic source that I could find to detail the pathways of hepatorenal syndrome physiology. However, they can be summarized. There are multiple mechanisms that lead to decreased tissue and organ perfusion, and ultimately these lead to poor kidney perfusion. So prerenal is just another word for decreased kidney perfusion, and a patient can have decreased kidney perfusion at any volume status, whether they're hypovolemic, euvolemic, or hypervolemic. It is important to recognize that many patients with hepatorenal syndrome also have cardiac dysfunction as part of their presentation, and there are important interactions between the kidney and the heart, as well as the kidney and the liver, and also between the liver and the heart. And so there's this concept that's growing called the hepatocardiorenal syndrome, and I think that that's important to keep in mind. An important aspect of the hepatorenal syndrome is a profound arteriolar constriction that seems to be reversible if the liver dysfunction is corrected or if the kidney is harvested and placed into somebody's body who does not have liver dysfunction. And this is very important because the renal tubules are particularly sensitive to hypotension and hypoperfusion because they are the only organ in the body whose artery has already passed through a capillary bed, namely that of the glomerulus. And here is a proposed model for how hepatorenal syndrome pre-renal states lead to ischemia and then tubular necrosis as the poor perfusion continues over time and may worsen over time. Here's a summary of many of the important mechanisms of acute kidney injury in the hepatorenal syndrome. There's a major component of a systemic inflammatory response. There are also vascular mechanisms, namely the renal arterial constriction and also arteriodilation in other portions of the systemic circulation, including splanchnic pooling. There's also a component of cardiac dysfunction, which leads to arterial hyperperfusion as well as venous congestion. And along the theme of venous congestion, there is also an abdominal compartment syndrome, which may also have a component from accumulation of ascites. As our understanding of hepatorenal syndrome has improved over time, so our definitions have changed over time, and I am not trying to make a comprehensive detailing of the list of criteria for diagnosing hepatorenal syndrome over the years, but merely to show you some major signposts along the way. In 2012, this was what we had basically for a definition of hepatorenal syndrome type 1, which would now be termed HRS-AKI. You had decompensated cirrhosis or liver failure, which required ascites. You had AKI, which was defined by the Akin-Kdego-AKI staging criteria. You also had to have an idea that there was no intravascular volume depletion, and this was presumed to obtain if there was an absence of shock, and also there was a requirement that a recipe be applied to the patients, namely 2 days of withholding of diuretics and also albumin infusion, 1 gram per kilo per day, with a maximum of 100 grams per day for 2 days. And then there was also the requirement that there not be some other likely cause of AKI, for example, a renal parenchymal disease or evidence of obstruction or urinary retention. Last year when I presented, I got to complain about the state of the current definition for hepatorenal syndrome, but meanwhile there's been a very important update. Regarding the method of withholding diuretics and giving an albumin infusion, they have now added the very important language to do this when clinically indicated. And I think this is a very important recognition that when patients present with intravascular and extravascular volume overload, that withholding diuretics and actually adding more volume to the patient in the way of albumin can be a counterproductive move. But the definition is still problematic because they make no attempt to explain when this is actually clinically indicated. It is very important to note also that there still require there to be absence of strong evidence for an alternative explanation for acute kidney injury. And I think this is an important point as well, because clinicians are very eager to write hepatorenal syndrome on the chart of a patient with decompensated liver failure and acute kidney injury, when there are many potential causes of acute kidney injury. And here are some findings that may be suggestive of alternative causes, and it may be difficult to make a diagnosis of hepatorenal syndrome in such a patient, but you might make an argument that perhaps there is still some hepatorenal physiology going on. It just becomes difficult to prove. Changing gears now from definitions, let's talk about ultrasound-guided volume management of patients with decompensated liver failure and acute kidney injury. What would motivate us to do such a thing? Well, we recognize that there is a mismatch between intravascular and extravascular volume, especially in patients who have liver failure. We recognize this inherently because a patient with decompensated liver failure and ascites already has extravascular volume overload by definition when they present with ascites, and often they present with marked edema. And yet we recognize that intravascularly, many such patients are actually volume depleted, which motivates the recipe to hold diuretics and administer albumin. But just as there may be a mismatch, some patients may present both intravascularly and extravascularly volume overload, and the language of hepatocardiorenal syndrome perhaps lends itself to this recognition. And so how can you tell which patient is which? Perhaps ultrasound-guided volume management would be helpful. Also, in the United States, it took relatively longer time to have terlipressin approved by the FDA for treatment of hepatorenal syndrome, and part of this is the requirement that it be shown to perform better than a placebo. And in earlier clinical trials, there was a high rate of response in the placebo group for the hepatorenal syndrome trials. And I'm going to float a hypothesis that perhaps the reason why you have a high rate of response to placebo is because you have difficulty defining your clinical syndrome. And one of the possible difficulties is if these patients had abnormalities of volume status that could be treated adequately with supportive care, perhaps people who got a definition of hepatorenal syndrome responded to other supportive care and not necessarily hepatorenal syndrome specific treatment. There have been clinicians, including our group, that have hypothesized that there may be a high rate of response to patients who have IVC ultrasound-guided volume management. Another thing that might motivate us to have better volume assessments of our patients is the recognition that there is an increased risk of pulmonary edema with therapy where terlipressin and albumin are administered to patients. So how do we do this ultrasound volume assessment? Very briefly, the inferior vena cava is located near the midline of the patient, and its diameters and the variation in diameters are measured about 3 to 4 centimeters from the inlet to the right atrium, or about 1 centimeter below the hepatic vein. And a collapsibility index, the maximum diameter minus the minimum diameter, then divided by the maximum diameter to normalize. This gives you something called the collapsibility index. And so knowing the maximum diameter and the collapsibility for any dynamic measure of the intravascular volume, a greater change in the variable of interest, in this case the IVC collapsibility index, indicates that a patient is more likely to respond in a beneficial way to volume administration, or in the context of hepatorenal syndrome, holding diuretics and administering albumin. So you can see that when the IVC diameter varies over the respiratory cycle, this corresponds to the cardiac output changing over the respiratory cycle with changes in the right atrial pressure. And the right atrial pressure will change dynamically according to the negative inspiratory pressure used to draw air into the lungs. In a ventilated patient, this cycle would be reversed. If you were to pay attention to the waveform of the central venous pressure in such a patient, as opposed to just the mean CVP, you might notice an inspiratory dip in the central venous pressure in a patient who is more likely to be volume responsive. In a patient who is less likely to be volume responsive, more likely to be volume overloaded, you'll see an IVC diameter that is consistently large over the respiratory cycle. And when the right atrial pressure changes with inspiration, it changes in a way that intersection with cardiac output is not changed, and so the IVC diameter is not changed. And such patients would be less likely to show an inspiratory dip in the central venous pressure. And although this technique is not perfect, it does allow you to do something as a clinician. You might argue about what makes a patient euvolemic exactly, and it's a difficult question. But if a patient has a small and collapsing IVC diameter, then they are very unlikely to be hypervolemic, intravascularly at least. Extravascularly, they might have marked edema and ascites and so have a mismatch between the intravascular and extravascular volume. On the other hand, a patient who has a large IVC diameter with very little variation over the respiratory cycle is very unlikely to be intravascularly hypovolemic. And with that kind of an interpretation in mind, here is the way that we summarize our suggested interpretation of these findings, and this is adapted from the American Echocardiography Society guidelines, which are updated periodically, I think the most recent in 2022, but very little has changed since the original publication of Rutsky in 1996. So there is some prior art to what we did. Dr. Juan Carlos Velez did a study where he hypothesized that many patients with acute kidney injury and decompensated liver disease are misclassified as having hepatorenal syndrome. He used slightly different IVC criteria than I just showed you, but nonetheless showed that a large percent of his patients, 49%, were either intravascularly hypovolemic or hypervolemic by his criteria. And he also showed that a sizable fraction, 23% of the patients, improved in their kidney function with volume management guided by IVC ultrasound. And if patients can improve with ultrasound-guided volume management, this suggests that their classification as having hepatorenal syndrome may have been in error. Maybe they had a different cause of AKI. And I agree with that general hypothesis. We published a similar study later on that was observational, looking at patients from Los Angeles County Hospital. And we had strict inclusion criteria, which basically required that they meet the criteria for hepatorenal syndrome, and including having had 2 days of standardized administration of albumin and holding of diuretics, and that the creatinine did not improve within those 2 days. These patients also were required to have an ultrasound of their inferior vena cava at that 2-day mark. We also had many exclusion criteria that were designed to make sure that we could not rule out other acute kidney injury causes. We excluded patients where we couldn't evaluate the response to treatment either because they had very advanced chronic kidney disease or were on dialysis or had inadequate follow-up. And we also excluded patients where we could not rely on IVC ultrasound findings for various reasons. And our findings were very similar in the general interpretation. Using the criteria that I showed you earlier, adapted from American Society of Echocardiography, we found that 75% of our patients were either intravascularly hypervolemic or hypovolemic by ultrasound assessment. And in our cohort, 30% of the patients improved with volume management guided by IVC ultrasound, which would again suggest that their diagnosis of hepatorenal syndrome was in error, despite our being very strict with our inclusion and exclusion criteria to make sure that these patients would otherwise meet all criteria for hepatorenal syndrome by our current definitions, and maybe being even a little bit stricter just to make sure. Moving on to prevention and treatment of AKI and hepatorenal syndrome. Well, it involves every aspect of supportive liver care that I showed you at the beginning of the presentation, plus administration of vasoconstrictors and evaluation for liver transplant when appropriate. What is the idea of vasoconstrictor therapy in hepatorenal syndrome? Well, patients with hepatorenal syndrome may actually have different autoregulation of the renal blood flow and be much more susceptible to decrease in the renal perfusion pressure compared to normal physiology. And it has been demonstrated that patients with hepatorenal syndrome can actually improve when you can significantly increase the mean arterial pressure with vasopressors. And the goal is to actually increase the mean arterial pressure by 10 to 15 millimeters of mercury, which is probably much less than is actually achieved many times when we try to treat these patients. So by the standard protocols in our hospital at least, if you are to administer terlipressin, it is also required that you administer albumin to the patient. And I'll point out that in the CONFIRM trial, which was the basis for FDA approval for terlipressin in the United States, that we found that there was a greater than 3 times increase in the risk of respiratory failure in the arm of patients who received terlipressin and albumin compared to the placebo and standard care arm. I would suggest that perhaps this is an opportunity for improvement in the assessment of the volume status of our patients to try to prevent this complication. So why is it that we always have to give albumin with the terlipressin, at least by standard protocols? And my understanding is that most of the data underlying that practice comes from this study. One thing that I will point out, though, is that yes, the creatinine did improve in the arm that got albumin and terlipressin compared to the arm that got terlipressin alone. However, the increase in the mean arterial pressure was significant in the patients who got albumin and terlipressin, and the average mean arterial pressure actually decreased in the patients who got terlipressin without albumin. And so one can question whether the salient difference between these groups was the fact that they failed to increase the mean arterial pressure, rather than that one group got albumin and another group didn't. And I would suggest that another way to interpret these data is that it's very important to achieve the increase in the mean arterial pressure in the patients who are administered a medicine like terlipressin, and that failure may be the reason that this group didn't actually respond to the treatment. Because I've seen many patients who they would otherwise want to give terlipressin to who look like they're very volume overloaded. And as the nephrologist, I have to say, well, maybe this patient would benefit from administration of terlipressin, but if they already look overloaded to me, I sure wouldn't give them even more albumin. I might even consider giving them some diuretics at the same time to try to unload their congested heart. So in summary, it is difficult to assess the causes of acute kidney injury in patients who have decompensated liver failure and also acute kidney injury, especially since the risk of getting a kidney biopsy because of bleeding complications is very high when you have dysfunction in the coagulation cascade due to liver failure, as well as uremic platelet dysfunction. There are many mechanisms that lead in the pathophysiology of hepatorenal syndrome, but a final common pathway is that they all lead to poor kidney perfusion. The mainstay of supportive care in patients with hepatorenal syndrome includes all of the optimizations that we would do for a patient with acute kidney injury in decompensated liver disease for any reason of acute kidney injury, but also vasoconstrictors. I would suggest that some modifications, though, to widespread clinical technique, I would recommend that the volume status of each patient be individually assessed, and that we should abandon the idea of a default use of albumin and holding of diuretics. And I would additionally suggest that if patients present with both intravascular and extravascular volume overload, that they might actually benefit from initial therapy with diuretics. I will also suggest that assessment of the relative intravascular volume using ultrasound techniques may be a very valuable tool in managing these patients. Thank you very much for your time. It is my honor to have an opportunity to speak in front of you. I also thank my family who collaborated in this project and my wife who supports me through all of this. Thank you very much. Have a good day.